Thank you, George, and thank you for the previous discussion. So it's my turn now to discuss a bit further, and I think after Professor Wells' comments, now there will be more comments after my talk, but thank you for that. It was a great turn. So just to say a bit more, you already introduced the topic of my talk, so it's about the interstitial lung disease, or ILAs if you prefer, or preclinical ILD in patients with systemic autoimmune rheumatic diseases. We all know that. I think I don't have to say more. We know that the people of systemic autoimmune rheumatic disorders are at risk of developing, of course, ILD, and the prevalence varies across different subtypes of diseases. And I provide this table from a very recent systematic review showing the variability actually of ILD in each group. And if you prefer numbers and percentages, this is another figure that mentions and highlights that systemic sclerosis, mixed connective tissue disease, myositis are the top three CTDs that are associated with the development of ILD during the disease course, while rheumatoid arthritis has a percentage of 20 to 30 depending on the previous studies, although I want to highlight that previous month a systemic review and meta-analysis showed that actually there is a publication bias from expert centers that, and this percentage maybe is a bit more than expected, and the authors suggest that the percentage is 10 to 13 during the long disease course of rheumatoid arthritis. And why do we care? Because ILD drives mortality in these patients. We know that there are robust data in the literature, and delayed diagnosis of ILD in this population is associated with increased mortality. So early screening, early diagnosis is important. In particular, in patients with rheumatoid arthritis that I used as an example, because the majority of them develop ILD at any point during the disease course. It's difficult to identify. This very surprising study showed that 90% of patients with rheumatoid arthritis and interstitial lung disease on high RCT didn't express for dyspnea or shortening of breath or dry cough or any respiratory symptom that could lead the rheumatologist for screening for ILD. So this is impressive, but we have also to think about this special, let's say, group of patients with probably problems associated with exercise, arthritis, musculoskeletal problems, etc. So it's impressive, but we have to know that, so it could guide better our screening in these populations, because screening means that we want to screen asymptomatic patients where symptoms begin, then it's early diagnosis, and it's really challenging for the clinician. We all know that. And unfortunately, upon ILD development, maybe there is also progression in a percentage that is not really low, as you can see from the figure on the right. It's from the guidelines published in 2022. The estimated proportion of patients that are going to develop progressive phenotype is the blue shadow, so it's not really low. And you can see again that rheumatoid arthritis, scleroderma, and mixed connective tissue disease are, let's say, the top three for progression. We know the criteria very well. I'm not going to stay more, but again, it's impressive that studies show even asymptomatic patients will actually express progression. And why it's important? We need to detect early, because we can treat early and treat better. We have medication, we have antifibrotics, and nintedanib is approved for patients with progressive phenotype independent of the background disease of the initial diagnosis. And of course, the research is going on, so we have new targets, new pathogenetic mechanisms are emerging, and we have new treatment options, hopefully. Nerandomilast is in the game now with patients with pulmonary fibrosis, not only for the idiopathic forms, but also for patients with systemic autoimmune rheumatic diseases. As you can see, the results were very impressive with as an additional medication with nintedanib or with immunosuppression if needed in these patients. So what we need, we know we have to screen, we know we have to detect early, but we need better screening tools and better tools for ILD progression, for early identification, let's say, of ILD progression. What we have several studies showing some risk factors. So, for example, for rheumatoid arthritis, it seems that older age, male sex, history of smoking, the MUC5B minor allele presence, the active articular disease, elevated antibodies are associated with increased risks of ILD development in these patients. Experts in Spain recently published also some criteria associated with the respiratory symptoms. Of course, if a patient has respiratory symptoms, is going to be screened for ILD, or if there is Velcro-like crackles, but also if they take a score of at least 5 points of the list below, they should also screen based on the colleagues in Spain. There are more or less the risk factors that I showed you before. And for progression, less studies. Of course, we need to monitoring the patient and be close to the patient with higher CT as needed, clinical symptoms, as we said, good clinical examination, PFTs and exercise tests. But again, there are some risk factors proposed for progression, especially for scleroderma patients and rheumatoid arthritis patients, where we have more studies and more robust data. And last year, we also mentioned the guidelines that were published with ERS and Euler, and Professor Antoniou was the chair of these guidelines. So I think that it was a very, very nice opportunity to gather all this information and provide more precise guidelines in contrast to the previously published in 2023 by the American Thoracic Societies accordingly. And shortly I will present you the main recommendations about the early diagnosis and the risk stratification, the risk factors that need to be seen mostly in these patients. So the guidelines recommend the use of higher CT to screen patients with CDDs instead of pulmonary function tests and instead of lung ultrasound. Regarding the pulmonary function test, it's obvious from the studies in the literature that the sensitivity and specificity of lung function test was very, very low. So we cannot overlook the fact that higher CT remains the gold standard. Regarding the lung ultrasound, I would like to comment a bit further. I think that the main point of the authors was that there are not established protocols for lung ultrasound and not defined criteria for the definition of positivity for ILD. Although, as you can see from pooled analysis, the sensitivity specificity is really, really good. So just a small comment a bit later also on that. For now, guidelines suggest screening for patients with CDDs with higher CT. In scleroderma patients and in patients with mixed connective tissue diseases, all patients should be screened because of the high prevalence and the increased risk for progression. For patients in the other three groups, we need to stratify the risk. So there are some proposed risk factors, as you can see here, for patients with myopathies as Sjögren and Sjögren. Again, older age, in case of Sjögren, male sex, increased inflammatory markers, presence of antibodies, etc., or even some clinical signs. We discussed two cases earlier in the morning about amyopathic dermatomyositis that had some risk factors. Actually, if you want now to go back to the cases presentations, that there were risk factors for ILD progression in these patients. So we have from the literature some risk factors in these groups of patients. The unresolved question was, how often should we screen? We screen a diagnosis or we screen upon risk factors. If the results are negative, then how often should we screen? Should we rescreen? There was no recommendation for that. I think we need more data to answer, but we are, along with our colleagues rheumatologists, we should be aware and hopefully novel non-invasive tools and research that is going on will help us answer this unresolved question in the future. Regarding other tests that could help us in the diagnosis of ILD in these patients, of course, risk factors for progression should be also very carefully seen in this group of patients. BAL can be used mainly to exclude other diagnoses. Lung biopsy has no role anymore, I think we all agree on that. Lung function tests are important, but you have to be careful because we discussed about the sensitivity and specificity, and of course you can use the oxygen desaturation and patient-reported outcome measures, although for this there are low certainty of evidence. Regarding risk factors, we can say overall, in all CDDs, in all systemic autoimmune rheumatic disorders, it seems from current literature that the male sex, the active disease and systemic manifestations, the high titer of antibodies, increased inflammatory biomarkers, of course the higher CT pattern, I mean the UIP pattern, and the rapid progression of the CT scan extent, that these are main risk factors that lead to a better monitoring and close monitoring. I would not like to comment further on the pH component. That is a major, let's say, comorbidity, cause of deterioration, cause of disease progression, or a consequencing maybe of fibrosis. I think it's very important, and we should not miss this coexistence in our patient, but I think that next talks are going to be dedicated on the topic, so I'm not going to comment further. As I told you before, the 6-minute walk-in test and the patient-reported outcomes seem promising, but I think we need more studies since now we have only low certainty of evidence, so the panel could not make a strong recommendation for that. And regarding monitoring, we should repeat pulmonary function tests every 3 to 6 months during the first years and at least every 6 to 12 months thereafter. High RCT, of course, has radiation, so it's supposed to be less regularly performed. So every 1 or 2 years in patients with scleroderma, rheumatoid arthritis, and other CDDs, and more frequently in patients with myopathies. As we said before, they're at higher risk of progression. And of course, it's the role of the clinician and the close monitoring in its visit to identify suspected progression using the other tools and repeat PFTs and high RCT as needed. We discussed a bit about the risk factors for poor outcomes. Here is the table from the guidelines. I don't want to repeat myself. So in summary, the guidelines suggest screening for ILD with high RCT, mostly in patients with scleroderma and mixed connective tissue disease. In the other CDDs, screening should be guided by the presence of the risk factors that we discussed. At diagnosis, clinicians should assess prognosis, assess the risk factors that we discussed, and evaluate the risk of disease extent on high RCT at diagnosis and the other also components that we discussed. And monitoring should be, again, based on each patient, on the disease, on the risk of progression, on the disease subtype, and on patient risk factors. So we discussed that diagnosis of ILD, even in patients with CDDs, that we are all more familiar, and our colleagues rheumatologists are more aware of the existence of the development of ILD in this patient. Again, despite all this, current knowledge is often delayed, and this is associated with worse outcomes. Identification of progression is also delayed, even if we know that a patient developed ILD. We lost something in the follow-up, maybe all of us, and it seems that identification of progression is also delayed, so treatment is delayed, and lung function contributes to be lost. So it's a fact that PF in this patient is associated with high mortality, and so I think that's why we have to do more as community, and we do more actually, because currently there are a lot of multi-center studies, that evaluate artificial intelligence tools that we have already discussed in this conference today. There are also multicenter studies currently evaluating the ILD extension quantification in patients with systemic autoimmune rheumatic diseases in terms of early diagnosis and in terms of early detection of progression. Of course, we have genomic classifier, we have other tools, scoring algorithms that are currently under investigation, and also home monitoring. There are also studies evaluating this part, very, very interesting. If I have 2 more minutes, I would like to comment a bit on lung ultrasound and on biomarkers, because I think there's the dawn of a new era in this topic. We have many, many data about short telomere length. Patients with systemic autoimmune rheumatic diseases, such as patients with rheumatoid arthritis and scleroderma, have shorter telomere length, and this is associated also with worse prognosis, so with poor outcomes. And I think that with this is the latest study. This is why I present this, but there are a couple of studies, more than a couple actually, before that also support this data, and I think we should really reconsider the role of short telomere length in our algorithm as a non-invasive biomarker, as a tool. Additionally, maybe with other blood biomarkers such as MMPs, a recent study also by our friends rheumatologists about higher blood MMP7 and MMP9 in patients with ILD in rheumatoid arthritis. And I think that the best solution is to combine biomarkers, so a multi-biomarker panel would be ideal. We have enough data for patients with rheumatoid arthritis, with KL6, MMP7, for example, that I just showed to you, and genetic markers, such as shorter telomere length. So I think that these tools will help us later. And this systematic review and meta-analysis really highlights the role of 3 epithelial markers, KL6, surfactant protein A, and surfactant protein B, as epithelial biomarkers that can be identified easily in blood. So we are discussing about novel, non-invasive tools that could help us for early detection. And this study was also very recently published about the screening for ILD in patients with myopathies. We discussed a lot about the increased risk and the severity in this case of patients. So I think that this study provides really nice insights, combining serum KL6 and lung ultrasound. That is my second love about ILD screening. I truly hope that in the next guidelines, the results of our team and the other authors that have been published recently, nice studies showing the high sensitivity and specificity of lung ultrasound and really easy, non-invasive, non-radiation exposure tool that could help us in these patients. And I would say, based also on my experience with this multi-center study, that it was very easy to collaborate with rheumatologists that are very, very comfortable with this tool. So I think that we should rethink a bit about this question in the guidelines. The data are more and more after the publication of the guidelines. You have 3 nice studies. We also proved that in 93 out of 100 asymptomatic rheumatoid arthritis patients, ILD could be ruled out with lung ultrasound, so it can be used as an accurate diagnostic tool. Velcro, of course, is not the panacea for ILD detection at the clinic, during patient visit. And this systematic review and meta-analysis that was recently published, again, unfortunately after guidelines publication, I think confirms our result and our thought that we could actually propose this algorithm. This was a slide created by Maria Taula and myself after the publication in CHEST with this multicenter study. We think that a short protocol of 14 lung ultrasounds, lung intercostal spaces is enough to exclude ILD in patients with rheumatoid arthritis without respiratory symptoms, avoiding high RCT. So this is our proposition, and hopefully we have also nice results with the role of exhaled breath in diagnosis of ILD. That is another non-invasive tool, novel, with nice results that hopefully we will publish soon. And in our cohort, it seems that exhaled breath, a very simple technique, simpler even than PFTs, than spirometry, simple spirometry, short and comfortable for the patient. Discriminated, so exhaled breath discriminated easily patients with different ILD subtypes, CDDs versus IPF, CDDs versus chronic HP, etc. Also detected with a high accuracy the UIP versus non-UIP pattern, the BALF neutrophilia and eosinophilia that is also very useful for our field, and also showed a really nice association with the presence of MUC5B minor allele and the progression during the first year of follow-up. So thank you for your patience.